Do you have allergies? How do you know? Today, we're going to figure that out for you, or at least help you figure it out. We're going to go over what the symptoms are, how you know if you have allergies, how do you test for allergies, how do you treat allergies. We're going to talk about why medications may or may not work for you. How do you avoid allergies? Do you clean those air ducts or don't you clean those air ducts? And we're going to talk about kids. What happens when kids have allergies and how important it is to treat them early so they don't have adult problems. You're going to learn about all of that and more in today's episode of Vital Discourse. Good morning, good afternoon, good evening. Welcome to Vital Discourse. Today we're going to talk about allergies. Many people say that they have allergies. They complain of different types of symptoms. What we're going to break down today is what are allergies, what symptoms do we look for, what symptoms do we actually treat, what symptoms can we treat, and how do we treat it. We're coming into allergy season, so this is going to be a big topic for us. So tune in, and we'll get a lot of information.
Beautiful intro. How you doing, man?
Doing great. How about yourself? How are your allergies?
You know, I don't think I have allergies. I do get, like a lot of people, I mean, I will have some times where I'm driving around Houston and I suddenly get some sort of a reaction. But I was skin tested at my own place to test some of our serums and some of our patients' experience when we started our allergy program. So they did a skin test on me and nothing reacted. But you know, that's a good place to start. We all kind of think we know the allergy symptoms, and I don't think we do. I mean, those symptoms are kind of a final common pathway for a lot of things, right? So how do you know when you have allergies? What are they?
And that's the big question, right? So I can't tell you, and I'm sure you experience this, how many patients come in and they say, when I suggest they might have allergies, say, oh, I don't have allergies, right?
Yeah, or they say that I do have allergies. They come in saying, I have allergies. Oh, you were tested? Well, no. Well, so you don't really know. You have symptoms that might make you think you have allergies.
Right. So the point being is that there's kind of this common, let's call it an understanding, that people have as to what classic allergy symptoms are. Classic allergy symptoms: sneezing, watery, itchy eyes, runny nose, postnasal drip, which is mucus dripping through the back of your nose down into your throat, maybe causing some throat clearing or cough or some those types of things. Itching, skin rashes, those types of things. And that, realistically speaking, when you look at the average allergy patient that comes into our practices, that's what, maybe 30-40%, right? So the nasal congestion, the chronic sinusitis, the headache, those types of symptoms, the fatigue that people normally don't really relate to possibly being allergy is what really the general public kind of doesn't get. And so if we're going to answer the question, what are allergies? So allergies are an overactive part of your immune system. So there are two separate parts of your immune system. It's more complicated than that, but let's just put it that way. There's the part of your immune system that fights off infections, fights off cancers, things of that nature. There's the part of your immune system that reacts to things that are coming in that it doesn't like seeing, okay? And those are allergies, right? So different types of antibodies. So the type of antibody that fights off infection, IgG, versus the type of antibody that reacts when you're exposed to something you're allergic to is IgE. So what we see is that people that have allergy have elevated levels of IgE, the allergic antibody, to specific things. Things like dust, trees, weeds, grasses, molds. Your significant other. No, I'm only teasing. But I've gotten that a few times. Maybe I'm allergic to him or that type of thing. But so that's what allergy is. It's an overreaction. Too much antibody being produced.
I want to try to make a little bit of a caveat there and see how you react to it. Because I'm listening to you as though I'm a patient, but I'm also a doc. And one of the things the example that I like to give is that it's not an overreaction, it's a misidentification. And so if you look at how we develop our immune system, there's a Th1 and a Th2 pathway. What does that mean? Well, if everything goes normally, right, the certain types of cells inside your body take in things from the outside and present it to our immune system. The CD4 cells that do that are slightly different in people that eventually develop allergies. So you're actually misidentifying things that are innocuous, that don't cause you harm, as though they're a bacteria or a virus, and your body is responding accordingly. And the example that I like to use, which, again, you can tell me if this is something that resonates with you. I have 2 dogs. 2 tiny little dogs, and their behavior I present to folks as an appropriate immune response and a bad. Pepper, my dog Pepper, is a yappy little knucklehead who sits in front of the doorway and looks out, and if there's any movement in the neighborhood, she freaks out and barks and tries to warn us that somebody's trying to kill us. That's an allergic response. You're looking at things that have no bearing on us whatsoever, and you're reacting as though it's a threat. And then Barney, who's kind of a lovable, sweet, dopey dog, just kind of sits around and doesn't respond to anything. But if we're walking outside and we've actually had somebody by accident sort of step in as though they were going to do something close to my wife, and that dog leapt at him and went after him. Because it appeared to be a threat that was coming in. And I kind of think we want to be more like Barney and a lot less like Pepper. You're reacting to stuff floating around in the air that your body should say, that doesn't matter.
So I respectfully have a different take on it.
Yeah, tell me. I like this. I want to know your take.
Yeah, so my take on it really comes from, for example, if we look at peanut allergy. So peanut allergy in children has been something that's really, seen a lot of media coverage and whatnot of late. And when we look at, for example, a country like Israel, which has little or no peanut allergy, versus the United States, which has had a very, very high number or percentage of children that have ended up becoming peanut allergic. What's the difference? The difference is when the peanut was introduced. So peanut is introduced in Israel within the first 3 months of life in the form of bombas. They almost look like Cheetos, but it's covered with peanut dust, so to speak, instead of cheese. And so they're exposed early, and they tend not to get peanut allergy. And so when they're exposed later, to a certain extent, I get what you're saying in terms of the misidentification. Okay, it's being exposed later, and they're saying, okay, this shouldn't be there. But I still believe it's an overreaction, because what really is going on, if you look at before industrialization, the level of allergy was significantly lower than after industrialization. And what do these substances do when they enter our airways? Even if they don't stimulate an allergic response, it is foreign material in our airways that causes irritation and or inflammation, even without an allergic response.
If it's presented properly to you, which includes early presentation to the appropriate CD cell, CD4, a Th1 instead of a Th2, you shouldn't be reacting to it at all. That's why I stay away from the idea of overreaction. That shouldn't be part of your repertoire. You misidentify. Maybe it's better to say that you misidentify first. The first thing is that you're misidentifying this as something that's a danger to you, and then you're overreacting to it. Maybe that sequence would sit better with us.
But my argument is that it is a danger to you.
Peanuts are a danger to you?
Yeah. So the thing is if you are sitting in a room full of dust and mold, and you're inhaling it day after day, forget whether or not you have an allergic reaction to it. Just the overload of microparticles that are going in and out of your airway that your airway has to deal with is causing an irritative reaction outside of allergy. And it's no different. It's no different than what's the sneeze. The sneeze is trying to get rid of something that's coming in that your body is saying, hey, that shouldn't be in my nose. I don't want to get all the way down to my airway.
That's an appropriate reaction, right, to an overload that's mechanical.
Right.
But we're talking about, so the symptoms and problems come with your reaction to it, not with the dust and mold particles. And so again, like we just had a mold scare. So we had mold inside our house. And we're not talking about Stachybotrys, which can kill you. We're talking about just an overload of mold. I was unaware of it. My wife knew because she's allergic to it, and she was miserable for almost 2 months. We couldn't figure out what the hell was going on. I wasn't at all. I felt great. I felt totally fine. It was the reaction to it, not the problem.
So, but here's the problem. I don't know, and we don't know the answer to this. I don't know that the body doesn't look at it and say, we don't know if this is Stachybotrys, right? We don't know if this is something.
Well, no, we do. The body does know, right? So those are antigenic determinants in the wall.
No. I disagree. The body knows it's Stachybotrys only from the perspective of it sees it, it creates an antibody against it. It doesn't know.
You're talking about a priori. You're talking about the first exposure.
Correct.
The body doesn't know.
Correct.
Yeah.
It doesn't know.
Fair enough.
And it doesn't necessarily know what Stachybotrys mold can do versus what Aspergillus mold can do. I don't believe that the body has that understanding.
On first presentation.
Correct. Or even on subsequent. I don't think the body understands the difference between them in terms of what other things it can cause in your system. Okay? And so because the body doesn't necessarily know that, I believe the body just doesn't want any of it because it doesn't know what it's going to do to the body.
Well, you're right. It's self versus non-self. First, the first thing is this me? Is it not me?
Right. And I think when it sees that overload, that it determines we need to get rid of this. We need to get the person that we're in out of this, right? So what do you tend to do when you're exposed to something and you know whenever I'm exposed to that, I know I'm going to have symptoms. You try not to expose yourself. So from my perspective, the allergic reaction is the body's saying, hey, we're going to give you some symptoms that's going to make you get out of there so you stop being exposed. I'm going to tell you. The only way I can tell you, I can't talk to you. The only way I can tell you is by making you congested or producing a bunch of excess mucus to try and flush this stuff out.
If that were true, then everybody would experience it, and everyone doesn't.
That's why, from my perspective, I believe that some people, their immune system is more reactive, overreactive. I will tell you this. I think that most people, if they have enough exposure, because some people are more allergic than others, and we know that. We know there's a genetic component to this.
There is a genetic component for sure.
Right. And some of that genetic component can be come from, well, what's our lineage? Where are we from? Wherever we're from, there was more of an issue that made it more dangerous to be exposed to whatever that was, because there were some exposures to something similar to that might have caused danger in our lineage, right? So I think all of this has to come in. I think it's to make it simple.
I think you were absolutely right when you said it was the way that it's presented in the time frame, because you know who doesn't get allergies ever are pica, kids that eat dirt. You have massive exposure when you're really young to a massive variety of things in the environment, kind of sets you up for a non-allergic pathway later in life. We know that, so we kind of know the gross the gross plus minus of that.
Right. So here we are, right? This brings up a great point. So long time ago, okay? We're talking centuries ago. What were the migration patterns? They were limited. You were born somewhere, you grew up there, your exposures never changed. What happens now? You can be born somewhere, you move here, you move there, other people come in, your habitat itself changes over time, industrialization, whatever it might be. The body is used to, and it's designed such that in the early part of life, the early months of life, it takes a sample of everything around it. And when it takes that sample of everything around it, it says, this is my habitat. Everything that I'm exposed to in this habitat is good and normal. Everything that isn't, I got to be worried about, and I'm going to start reacting. And that's why we go back to the peanut allergy. When it's exposed early, no allergy. When it's exposed later, it looks at it as a foreign material that it needs to react to. Now, sometimes that's good because, like I said, there are certain molds that we need to stay away from, but obviously sometimes that's bad. But look, we've beaten this dead horse. Whether we say that it's overreaction or we say that it's mischaracterization, either way, the immune system is reacting to whatever it is that you're being exposed to, and you don't necessarily get born with allergy, and that allergy follows you throughout your life.
One thing we should mention here, though, Lee, while we're on this topic, is that there is a high correlation with the overutilization of antibiotics early in life with the development of allergies later. So that kind of goes with what we were saying about how something's presented to you. If you hamper the normal, the thought process is if you hamper the normal pattern of exposure, response, and then resolution, and you introduce antibiotics in there, it doesn't present it the right way. So it's something that folks should think about when they're running to the ER to get an antibiotic for the fever that they just developed. So there's great epidemiologic evidence that overutilization of antibiotics plays some sort of a role here.
And to your point, those exposures early on as our immune system is developing, those set the stage for our immune system going forward. And if we don't get that exposure appropriately, in other words, to your point, using things like antibiotic to limit that exposure, our immune system can't react properly going forward.
Absolutely. And think about it, it's kind of our fault, especially in the US, where you're terrified when a child gets a fever. And rightfully so, it can cause some problems, but we run to the ER. The ER workers and urgent care folks are overworked, and the kid's tugging at his ear, which doesn't necessarily mean that they have an ear infection, but they claim it's an ear infection. They give him antibiotics and get him out the door in 7 minutes, and they use it over and over and over again, and that can be it can have some detrimental effects down the road.
So now the other thing to really kind of key on here is that allergies can change as time goes on.
Yeah.
So the immune system is constantly changing, constantly adapting. So I'll have patients that'll come in and say, "Oh, well, I've never had allergies. Why would I have allergies now?" But adult onset allergy is real. Can you speak to that?
Nobody ever has anything before it starts.
Right, but why all of a sudden would allergies start as an adult?
Well, quite often, if they start as an adult, if you really delve into it, they did have some issues when they were younger, and then there was a period of normalcy for a while. That's very common. It's a bimodal distribution, the beginning, quote unquote, beginning of allergies. It's early life to teens, and then sort of a normal area, and then 35 to 55, they develop as well.
So in my practice, what I see is basically three categories. I see the person who has allergies when they're young, that it's treated very early, many times with allergy immunotherapy, and they never have an issue with allergies again. Then I see the bimodal distribution that you were talking about, allergies young, allergies again, middle-aged. Then I see the constant forever allergy patient, always having allergy. That's usually the asthmatics, the chronic sinusitis patients with polyps, those types of things. Very, very severe allergy. And I find those are more, as you were speaking to before, those kids that were treated with antibiotics over and over and over again. They also have genetic predisposition. We should say if one parent has allergy, the chance of an individual child having allergy is 50%. If both parents have allergy, the chance of an individual child having allergy is 75%. So there's a very, very strong genetic predisposition for allergy.
Yeah.
Let's move on. How do we tell if allergy is, if what the symptoms that we're treating or that we're feeling, I should say, are actually allergy?
Yeah, what's your algorithm when somebody comes in, whether they tell you, hey, I have allergies or not? How do you start picking this apart?
So I would say that in the head and neck region that we deal with, that allergy is always on my differential list. Always, because it can be the great imitator. So you can get people that their only symptom of allergy is headache. Their only symptom of allergy is vertigo. Their only symptom of allergy is fullness in their ears. Their only symptom of allergy is brain fog, difficulty concentrating. So it's always on my differential. Now, when someone has kind of the more classic symptoms, that's pretty obvious: sneezing, watery, itchy eyes, runny nose. Changes in season cause a change. Outdoors versus indoors. Hey, whenever I'm exposed to Aunt Sadie's cat, right? Those are the obvious ones. Those are the easy ones. But it becomes more difficult when someone's complaining of, for example, I have been congested with a headache, having difficulty breathing through my nose and a headache for the last 3 months. Prior to that, I never had a problem. Is that new onset allergy? Is that a new exposure? Is that a sinusitis that was never treated? So it has to be in your differential at that point.
Let me ask you a question here, Lee. And I want to know this to see if it coincides with my experience with patients. Do you find that there's a correlation, no matter how subtle, with typical nasal symptoms, congestion, drainage, sneezing, and degree of physical obstruction of the nose? In other words, not as much sneezing and posterior nasal drainage because they have a deviated septum completely walling off 90% of their mucosa in their nose until you fix it. Do you ever find that? And then if you fix their nose, they do develop more sneezing and postnasal drip because you've increased the surface area inside their nose?
Absolutely. And I usually tell patients that straightening a nasal septum or improving nasal airflow is a double-edged sword when it comes to allergy. You might not have had any classic allergy symptoms prior to improving nasal airflow, but once nasal airflow is improved, you have increased exposure and you could start having allergy symptoms that you didn't have before. So absolutely, I definitely see that. However, I also see something that my take on it might be a little bit different than most. And that is, from my perspective, the most common cause of postnasal drip or excess mucus production is actually nasal obstruction and is not allergy. And the reason I say that is I believe that there's a reflex arc where when there's decreased airflow in the nose, certain areas of the lining of the nose are not getting airflow. The lining of the nose doesn't know why. There's a presumption that there's an obstruction in the nose. There's something stuck in the nose, and the nose produces excess mucus to try and flush it out. Now, that's just my opinion. I haven't seen that in any specific, journal articles or anything like that. But I can tell you that the vast, vast majority of my patients that come in with nasal obstruction and excess mucus production, whether it's runny nose or postnasal drip, it is almost completely gone after we reestablish nasal airflow. How about in your case?
Yeah, I mean, that's certainly a subset. I did the reason, so when I fix somebody's septum, they have a really badly deviated septum, for whatever reason they came in for. I look, I see that the septum's deviated. It's either, a snoring or a nasal obstruction or you name it. Quite often I'll test them I test everybody. I tell them, look, I'm going to test your allergies because my experience in the Navy was about 60% of people, I would fix the septum. They'd come back in 2 months saying, Doc, you gave me allergies. I didn't have allergies before, but now I'm sneezing and I get drainage. I don't have any congestion anymore. I'm not stuffy, but I'm pouring fluid down the back of my throat now, and I didn't have that before the surgery. So I instituted a practice of testing everybody if they're coming in. And I find that, again, it's about 65% of the folks that are coming into me for some level of congestion or snoring wind up having an allergy that they weren't aware of.
So we've established that from a symptom perspective, allergies can give you almost everything. Sneezing, watery, itchy eyes, runny nose, postnasal drip, cough, headache, fatigue. All these symptoms can be referable to allergy. Dizziness, classic what people call vertigo, chronic cough. So we've established that. Now, what do most people do? So the average person goes ahead and usually will treat themselves, right? Over-the-counter types of medications. Things like antihistamines, things like decongestants. Ben, there are antihistamines and then there are decongestants. And we have people come in and say, well, it can't be allergy because I took Claritin or I took Zyrtec or I took Allegra and it didn't get better. My congestion didn't get better. Does that mean they don't have allergy?
Absolutely not. I tell people this all the time. That's a great point. That you can be physically obstructed. You can be temporarily obstructed by swelling tissue. You could have a deviated septum or concha bullosa or something that's physically blocking the nose, and then or narrowing it. And then you can have relative inflammation inside of there that will give you a blockage in your nose. And you can affect those things in two ways. You can prevent histamine from causing the swelling, which is like an antihistamine, or you can shrink down those blood vessels with a decongestant, and it will temporarily shrink that lining and allow air to sneak through. And so there's a lot of different ways. There's also pollution in cities like Miami and Houston causing some of that lining to swell. So just because taking a single Claritin or a Zyrtec doesn't completely alleviate all your symptoms doesn't mean that you don't have allergies. Again, I always tell them, if you haven't tested, you don't know if you have allergies.
And I explained it further. We know that there are early phase allergic reactions, sneezing, watery, itchy eyes, runny nose, and late phase allergic reactions, largely inflammation. And certain allergens will cause one versus the other. Antihistamines do a really great job with early phase reactions, but they don't do a great job with late phase reactions. And that's the reason that you have Claritin D, Zyrtec D, Allegra D, because you want in those combination drugs are treating both the early phase and late phase allergic reactions. So that tends to be the reason if you're a late phaser, right? The antihistamine itself is not going to open your nose, so to speak, because the inflammatory process is largely a late phase reaction that antihistamine doesn't really work on.
Singulair will help with that also. And so, you want to try and make sure you understand what that person's combination reaction is before you start ruling out just based on testing them with different meds.
And what's your feeling on the black box warning of Singulair? Because I tend to not put patients on Singulair because of it and try to get patients off of it when they come in. What's your experience been?
We talked about the black box warning. I just don't get that a lot. I do sometimes, and I always bring it up to patients. Things like Levaquin that has a black box warning, but you need it for certain really difficult to cure infections. I always bring it up as well. I don't completely avoid it because of it, but sometimes, especially when there's late phase associated with headache, I've had great results with putting people on it. But I also warn them, and the first sign of any problem with it, no matter how subtle, we take them off.
So just so people know what the black box warning is for Singulair, what it is that with extended use, there have been people that have developed psychosis and even suicidal ideation. So that's what the black box warning is on Singulair. So just if you're told to take Singulair, just to understand what that black box warning is. Speak with your practitioner about it.
With that said, I've never had that happen, and so I don't really have a lot of feedback telling me that it's a very prevalent issue.
So, Dr. Ben, I've taken the over-the-counter medications. I've used antihistamines. I've used decongestants. I've used over-the-counter Flonase, which is a nasal steroid spray, and my symptoms aren't getting better. What's going on?
So that goes to algorithm, right? I mean, a fairly typical algorithm is that I want to try and understand what's happening to this person. And depending on what their slant is coming in, I'm either going to set them up for a test to see if there is an allergic component to what's happening. And I also want to evaluate the inside of their nose and sinuses to make sure there isn't chronic sinusitis going on here. And so for two reasons. One, the treatment pathway is completely the opposite. If somebody has obvious chronic sinusitis, I'm going to want to treat them with some antibiotics, plus or minus steroids or a steroid spray. But if they have clearly just intranasal swelling, and I look inside their nose with a scope, and I see cobblestoning, and I see other signs that tell me it's probably allergy, I'm going to get an allergy test. I'm going to treat them appropriately to tell the difference between vasomotor rhinitis, just your non-immunologically based reaction to the environment around you, or allergic. So non-allergic rhinitis or allergic rhinitis. That's kind of the rough algorithm. Does that jive with where you go with it?
Yeah, and what I see many times is patients that have been treated by, for example, their primary care physician or by an urgent care or whatnot, using the classic allergy medications, and then coming in and I look in their nose and they've got nasal polyps. Well, we know antihistamines and decongestants aren't getting rid of nasal polyps. That's a very advanced immunologic reaction that needs to be treated.
Neither are antibiotics.
Yeah, in a completely different method. And same thing, to your point, chronic sinusitis. Sometimes acute sinusitis that hasn't been treated over a long period of time that's turned chronic, and now there are changes in the bone, and it's really become a nasty issue to deal with. So just because, if the medications aren't working, the bottom line is that's really a time to seek an expert specialist opinion, because when those medications aren't working, there's probably something else going on, or your allergy is at a level where it needs treatment with things like immunotherapy, which is the next thing we're going to get to. How then do we treat allergy, for example, when medications aren't working, or how do we treat allergy so we don't have to take medications? Because who wants to take medications all the time?
Yeah, that's so funny. There's two camps of people, right, with allergy. There's a clear delineation. There are the people that come in saying, look, I'm very natural. I don't want to take medications at all. And there are people that say, well, I don't really know what's going on with drops or shots. Let me just take these meds because I can stop. I can control it myself, and I can stop them anytime that I want. There's some overlap, but usually it's those two camps. And so what we're talking about is immunotherapy, which is trying to redirect your immune pathway from a Th2 to a Th1. We want to start to actually identify things, categorize them appropriately as non-harmful, and stop reacting to them. And the only way to really do that that we know of today is to go back to how we start to characterize things and make that switch, take the train tracks and switch it from that train going to Miami and make it go to New York. You want to take the CD4 cells, these little cells underneath the skin, and dendritic cells, or underneath the tongue, called antigen-presenting cells, chew up this antigen, these little bits of things that are part of that particle, the pollen or bacteria or viruses, get chewed up by these APC cells, and they and they deliver them to a type of cell in your immune system, either a CD4 cell that's either a Th2 or a Th1, and you want to switch that from Th2, which is considered to be an allergic pathway, switches it to the Th1 so it starts to appropriately react to bacteria and viruses instead of things that are just floating around in the air. So immunotherapy under the tongue is very helpful. It's easy to use. It's effective, and it's cheap. And there's really not a reaction that's dangerous to you at any real rate. Under the skin is kind of a leftover vestige from the time when we were in the late 1800s, early 1900s, when we were developing immunizations. And so it presents to different cells, but same process. The problem with it involves injections, and it can be dangerous, so you have to come sit in my office and make sure you don't get an exuberant reaction that could threaten your airway.
Most parts of Europe actually don't offer allergy shots. They only offer oral immunotherapy, and that's because of the inherent dangers of injection immunotherapy.
Look, like we said, the kids that eat dirt don't get allergies. I mean, children's behavior when they're little is to stick stuff in their mouth. And over-cleaning, stopping them from doing that, I think it's part of why, again, it's multifactorial, part of why we have in the first world a heck of a lot more allergy than in places like my wife was from the Philippines. They don't really have allergy clinics there because they don't really have a whole lot of allergies. It's a first world problem more than the third world problem.
So I guess we should abandon the 3-second rule for when something falls on the floor for our kids to eat.
Yeah, well, if you're in this vein, yeah, I mean, it's not the most important thing in the world,
Absolutely.
Right?
The way I usually explain it to patients, what we're doing is that there's a parent cell. And the parent cell will either produce IgG, which we said was the antibody that fights off infections and cancers and those kind of things, or it can make IgE, which is the allergic antibody. Right now, your parent cells are producing more IgE and less IgG, okay? We've got to get it to switch, right? Which is what Dr. Ben was talking about. We've got to get it to switch to producing more IgG and less IgE. And the way we do that is with a classic immunization. So the same way you get immunized for flu or you get immunized for mumps or measles or rubella, it's the same type of thing. The only difference is I can't give you 1 million units of dust antigen if you're allergic to dust because you'll have an overwhelming reaction to it. So what I need to do is I need to give you very small amounts, an amount that the allergic arm of your immune system can't see, but that the non-allergic arm of your immune system, the IgG part, can see. And so what happens is when the IgG part of your immune system can see it, it starts producing more and more of that IgG antibody against that dust. And your really high levels of IgE to dust and low levels of IgG to dust over time switch. And when that switches, you're immunized. How long does it take for that to happen? Usually it takes about 3 years for that to happen. Sometimes a little bit longer. It really depends. Certainly, if I'm having someone that after 3 years of treatment is still having symptoms, I would retest. From my perspective, at that point, and maybe even before that point, I feel that there must be an allergen out there that was missed in the original testing. How do you do that, Ben?
Lee, I got to tell you, that's an excellent Bob the Builder way to look at allergies, and I think that's a great way to present it to patients. I tend to get too technical sometimes, and sometimes the message is lost because I go way into details that maybe they're not excited about or don't know about.
That's because you're not a simpleton like me.
No, I love it. I think it's great. And so for me, 100%, I talk to people about that from the beginning, that it takes 3 to 5 years, that you're whispering to the immune system. The cells under your tongue, because children stick things in their mouth, those cells under your tongue are uniquely specialized to do this whispering to the immune system in a great way. So what do I mean by that? Well, you're taking the things that you're allergic to, grinding it up and putting it into a glycerin drop. So those folks that want to only be natural, this is as natural as you get. You're basically taking them through what a child did in the appropriate environment in their house when they're not pulling things out of their mouth that fell on the floor, to Lee's point. So you drop this stuff under your tongue, and it starts to tell the immune system through the appropriate antigen-presenting cell pathway, this is not a problem. And you want to do it, like you said, in a very low level. But actually, you can even put higher levels in under the tongue, and it doesn't trigger anaphylactic response that you need to slam yourself with an EpiPen for, whereas under the skin, you're at a very delicate balance. So very important to kind of pay attention to the safety levels. One thing I would say from what you were talking about, if anybody, and I see allergists even make this problem, there's a lot of data coming out of the Quad AI, which is the American Academy of Allergy and Immunology, Allergy, Asthma, and Immunology. There's great data showing that the size of the wheal on a skin test does not mean that you have more or less allergy. So it's a plus or minus. That data is fairly settled, actually. So in other words, if it's more than 4 millimeter wheal on your arm after they introduce that little allergen under your skin, that's positive for allergies. And then you try to correlate it with what you know to be true throughout your day and year. If it's 15 millimeters, you can't effectively say, oh, that means you're really allergic to that. It doesn't work that way. But I hear that from a lot of people. Well, I only had small wheals, so they didn't treat me. Not really the way to do it.
Since you started talking about wheals, let's talk a little bit about what allergy testing is. So allergy testing can be done in a couple of different ways. There is allergy skin testing, and then there's allergy testing through a blood test. So allergy skin testing, which is a provocative test, basically what you're doing is you're presenting an antigen, something someone might be allergic to the body to see what the body's reaction is. When you're doing blood testing, you're looking at a secondary event. You're looking at a reaction, just an antibody that may have been produced when someone was exposed to an antigen. The problem with that type of testing, which is called RAST testing, is that those antibodies only stay around for a certain amount of time. And so depending on when your exposure was, so for example, if I test you via a blood test for ragweed 3 weeks before ragweed season starts and you haven't seen ragweed for 9 months, the likelihood that you're going to have high levels of ragweed IgE in your bloodstream is pretty low, right? So it can give us false negatives when you do blood testing, number one. Number two, it's hard to treat off of that because you really don't know exactly how much antigen to treat with when you're doing your immunotherapy, if you're doing allergy shot therapy. Okay, so that's the kind of the difference between the two. Now, what Dr. Ben was talking about in terms of the wheals, when you're doing allergy skin testing, you're taking a little bit of what you're allergic to and you're putting it into the skin, intradermal injection, and then you're seeing what the body's reaction is to it. Classically, the best way to do a provocative test is stick someone in a room, close everything off, blow a bunch of dust in there, see if they start sneezing and get congested, and hey, yeah, you're allergic to that, but we can't do that. Right? That's not something that we realistically could actually accomplish. So
diagnostic pillow fights.
Right. So skin testing is the next best way to do that. And that's how we do it. And that's when Dr. Ben was talking about that. And the way I explain what Dr. Ben was talking about is that just because you have a larger reaction to one thing that you might be allergic to over another thing you might be allergic to on your skin test on your arm doesn't mean that when you're exposed to that, you're going to get a greater reaction than something else. Why is that? One thing is that you might be exposed to much higher amounts of the thing that you are quote unquote less allergic to and therefore more apt to have a symptom. The other thing is certain items, certain antigens are more antigenic. mean they generally promote more symptoms than other antigens. Great example, cat, very, very antigenic. People that are allergic to cat can have very small reactions on skin testing, but very big symptom complexes when they're exposed to cat. Another one, Melaleuca tree. So Melaleuca trees we have here in South Florida, the antigen is very dense, it's very heavy. So when the antigen comes off the tree, it tends to go right to the ground. It really doesn't get spread very far. So you could have a very significant Melaleuca reaction, but if the closest Melaleuca tree is 10 miles away, you're not going to react to it. And so it's really not a major issue for you. So that's the way I explain it to patients.
Pretty similar way that I explain it as well.
So moving on, other ways to treat allergy other than immunotherapy. Let's talk about avoidance. How do you avoid allergens? Dr. Bennett.
It depends on the allergen, right? It's super hard to avoid cat dander. Cat hair, yes, but cat dander. To your point, some of the tests that were done when you have a dander counter, you could go into an Olympic-sized gym, and if a cat is introduced at one corner and your kitty corner, within about 10 minutes, you'll start picking up dander in the air on that counter. So it also gets into your clothes, gets into the carpet, gets into everything in your house. So you may be allergic to cat and not have a cat, but are you avoiding it? What if people in your office have a cat, and now you're sitting there next to them, and it's all over their clothing and all over their skin? So avoidance is sometimes easy, sometimes it's subtle, and you're not sure whether you really can or not. Plus, just getting rid of the cat, some people have had to move because it's such a heavy burden of dander inside the furniture and the drapes and the carpet, you just can't get rid of it. Usually, dust, is one of the things that it's also really hard to get away from or avoid. But there's a lot of things that we tell you. We tell you to put barriers on your mattresses, to cover your pillows and wash your sheets in hot water, have a HEPA filtration system in your house that has certain parameters to it, how many times it recirculates the air in the room and what micron level of particles it's taking out of the air. So there's a bit of a science and an industry that's developed around avoidance. Sometimes it's possible, sometimes it's not. But first you have to identify what you're allergic to, and then your relative ability to stay away from it. You were saying about the Melaleuca trees, very interesting. I didn't know that. We don't really have a lot of those here that I know of, but we live right below one of the largest piney forests in the U.S., and so I can tell you right about now, we have a thick dusting of gold that settles over everything no matter how many times you wash the car. And that's the pine trees starting to put out their pollen as part of their life cycle. And so avoiding that, good luck. Very difficult. And we have a high utilization rate in my clinic of people that can't get away from it. So yeah, it's based on their testing and the relative ability to stay away from it. Staying indoors without HEPA filtration and without surfaces that you can easily wipe down is probably not going to work all that well to keep dust out or pollen or the things that are blooming at any given time out. But if you do have hermetically sealed windows and you have HEPA filtration and hardwood floors that you can easily mop up, you can stay away from it if you're willing to not go to work or school for a couple of weeks during the highest bloom.
Yeah, going back to what you were talking about with cat, so I read an article one time that said that if you remove a cat from a home, completely clean it, try and sterilize it, you will still find cat antigen in that home for at least 2 years afterwards. That's how hard it is to get rid of cat antigen.
Exactly.
And the most antigenic part of the cat is its saliva. and they lick everything. And the saliva is very sticky, so it gets on absolutely everything. And that's the reason that we always test for cat, even if you don't have a cat.
Well, just remember too, Lee, there's a difference between cat hair allergy and cat dander allergy. And what we've been talking about is the dander. The hair is not quite as bad. Still bad, but not quite as bad.
And cats lick themselves all over. So that saliva gets all over, and that creates the dander, quote unquote. But the point being is that we always test people for cat, even if they don't have cats, because the antigen is so ubiquitous. It's literally everywhere. You can't get away from it. Things like Dr. Ben was talking about HEPA filters and for dust and boiling your sheets and those types of things. You can do everything that you can. Stop using ceiling fans. Make sure your ceiling fans are cleaned. Get rid of carpeting. Get rid of old books that you might be exposed to that could be dusty. Get rid of stuffed animals, stuffed toys, those types of things. You could do all of that stuff. Maybe you'll decrease your dust exposure by 10%. That's not a lot, right? Another thing that people do and that you can do is you can have an ultraviolet light put on your air handler of your air conditioning system, and that can limit some of the mold in the air conditioning system. Dr. Ben, what do you tell people when they ask you, should I get my ducts cleaned?
I don't really bother with testing for duck allergies, mainly because most people aren't allergic to ducks. But ducks, chickens, other birds, I don't bother with them, Lee.
I meant air ducts.
I know. Sorry. Yeah, I mean, look, you got to be careful with that, right? I mean, air ducts... we have there's two ways to do air ducts, and I'm assuming you mean for the air conditioning, not for the dryer. Is that right?
Correct.
Yeah. Look, so double-edged sword here. You got to be really careful. You can either have filters that are right in each intake, or you can have those main filters. And we have a filtration system. My wife has terrible allergies. We have a filtration system in each of the air handlers. So they're really big. They pull everything out at the source, but it leaves the air intakes completely free. And it also comes with an ultraviolet light that kills bacteria and viruses, supposedly, and molds. So if you go up and do that, remember, it's been gathering all of this dust and all these particles forever. You really have to handle that carefully, and probably the person that's super allergic, you don't want them to be doing it. So you want to, I actually also treat it almost like a hazmat situation. So I go up and take them out. I pull out that big block, and I immediately put it into a large yard, like a leaf bag, and I close it up and take it through the house. Then I replace it. So be very careful. Don't go up there. You've been very careful to filter everything out and get it away from the people that are allergic to it. And then you go up there and grab it and shake it around and walk through the house. And you just sort of defeated the purpose of filtering it in the first place. Same thing with vacuuming, by the way. There are HEPA filter vacuum bags. Be real careful vacuuming and then blowing that stuff all up into the air. If you look at the old-fashioned bags, they're not really sealed very well, and they don't have any sort of filtration, so it can really kick up a lot of the stuff that's sitting in your carpet.
Yeah, I tell people really the best thing you can do is get a high MERV rating air filter. So MERV rating basically tells you the size of the particles that are filtered out. So the higher the MERV rating, the smaller the size of particles, and therefore the better it is in terms of treating potential allergens being blown throughout the house. So get those, change them every month. Ultraviolet light on the air filter. Duct cleaning, I really, in my experience, hasn't made a difference at all. And most of the time, if the ducts are clean, 3 months later, you look at the ducts, they look exactly the same way that they looked before. I really don't think that makes much of a difference. As long as you're filtering the air appropriately, I think you've done basically what you need to do.
MERV, for me, I remember I was an Intel officer. MERV is a multiple targeted independent reentry vehicle. So it's a nuclear weapon thing. So I was cracking up when you were saying it.
Definitely don't get one of those for your allergies.
Right. Hey, listen, one way or another, you won't have allergies anymore. So,
So I wanted to touch on something a little bit different here, just kind of out of left field. Patients sometimes will come back and say, I've been on Flonase for a period of time, or I've been on Claritin for a period of time, and it's been working great, and then all of a sudden it stopped working. Reasons.
So quite often people just give folks a steroid, and this is an interesting thing about steroids, especially topical nasal steroids. You're kind of just blasting the mucosa with something that squashes, and it gives you an inability to react to things. It shrinks swelling. It reacts. It actually stops some of the some late phase and some early phase inflammation. But you're also destroying that mucosa. You're thinning it out, and you're damaging it essentially over time. And so your ability to affect that essentially lessens with time.
Yeah, so I find two different things. I find, number one, you could have someone that's developed chronic sinusitis, and it's far past just allergy at this point, and that could be why it's not getting better. And the second thing is tachyphylaxis. So certain medications, when the body just keeps seeing the same medication over time, it can become just less reactive to it. It could basically stop working. So that definitely happens with long-term medical usage and medical therapy. And then as Dr.
Same thing with antihistamines, by the way. You have to, if you're going to stay on them the rest of your life, you have to switch them every 1 to 2 years.
Yeah, and previously it was always classes, right? There were different types of antihistamines that were in different classes, and you say, okay, it's not working in this class, we'll switch you to one in that class. They're pretty much the ones out there now are all the same class. I do find that patients might respond better to one than the other.
That's because there are differences, though, like the chirality. They get isomers or different chiral partners, and the body sees them as slightly different.
And some cross the blood-brain barrier where others don't, and so that's where you get the fatigue with some and non-fatigue with others. Absolutely. We've gone through. We've really exhausted this, but the one thing that we really haven't talked about that I think people are really interested in is how do allergies really affect kids differently than adults? What should parents look for? How do we treat it differently? How do we test it differently? Are we using immunotherapy in children? Is that safe? What do you think?
Those are a bunch of really great questions. That's a loaded issue. Children are not just little adults. I mean, they do behave differently. Anybody who's ever given their child Benadryl knows, and then watch them bounce off the walls instead of fall asleep like you do, knows that they're wired differently. And so you have to understand it at a very different level if you're going to be treating them as a physician. So you want to make sure, because you're developing, one of the most, I think, difficult things to understand, to ascertain, and to navigate is how they are doing in school. I mean, a big marker for us as parents is developmental milestones. You can obviously see kids, with allergic shiners and a little crease above their nose because they're always wiping it. And we can sort of say, yeah, they might be allergic. But when you completely swell your nose shut, it starts a domino effect that can result in decreased school performance and decreased milestone or decreased, what do you call it? How do you say that? Decreased milestone meeting? Marking, I don't know. So basically, you want to make sure that the child is breathing properly, sleeping properly, and therefore doing well in school. Sometimes a child won't tell you what's wrong with them. It's their mood and behavior change. They start to get grumpy. They start to act out and have behavioral issues at school. You might see grades go down, but you also might hear from the teacher, they're really hard to control right now. They're having a lot of outbursts or they're falling asleep.
Yeah, and when the main issue for a child is nasal obstruction, not breathing through their nose, you see this when you see things like kids with enlarged adenoids, right? Enlarged adenoids, enlarged tonsils, generally in kids, that's actually an allergic phenomenon. But even just classic nasal obstruction from pure allergy, swelling in the lining of the nose, when a child is not breathing through their nose, there are changes in the facial skeleton. So the facial skeleton is actually changing, it's forming in childhood. You get an elongated face, an elongated jaw or mandible. And what can that lead to down the line? It can actually lead to adult obstructive sleep apnea, right? Which we've talked about sleep apnea ad nauseum in prior episodes. And
well, your midface doesn't develop either, and so you're right. You have this adenoid facies, these allergic facies. Yeah.
Yeah, so it really is a big deal, right? If you're going to catch this, you really do want to catch it early because childhood allergy can cause the development of these other types of things. Childhood allergy untreated also increases the risk significantly of adult asthma as well. So when should a parent look into this for their child? If their child is having chronic symptoms that are unresponsive to standard over-the-counter medical therapies that their pediatrician is recommending for them, then they should probably seek a specialist to look into the allergies more closely, and especially an otolaryngologist like ourselves to make sure there aren't issues such as chronic sinusitis, enlarged adenoids, enlarged tonsils that could also be contributing to the issue. So we have spoken about a lot of things here in terms of allergies today. We've spoken about, well, what kind of symptoms are allergic? How do we know if it's allergy? How do we test for it? How do we treat it? And we've really run the gamut of that. Now, we've speaking today about environmental allergy. We haven't spoken about things like food allergies and medication allergies and those types of things. We'll leave that for a separate time. But I think we've given you an exhaustive look on how we look for, how we treat allergies. Thank you so much for tuning into this episode of Vital Discourse, and we can't wait to see you again next time.